Here's a detailed explanation of left posterior hemiblock, LPHB, cover 1.1 Introduction. Left posterior hemiblock, LPHB, is a fascicular block, a type of intraventricular conduction disturbance involving the left posterior fascicle of the left bundle branch of the heart's conduction system. Though relatively uncommon, LPHB often signals underlying cardiac pathology such as ischemic heart disease or fibrotic degeneration of the conduction system. LPHB can be asymptomatic or may manifest with serious symptoms when associated with more extensive conduction disorders. Number 2. Definition. Left posterior hemiblock, LPHB, is a block or delay in the transmission of electrical impulses through the left posterior fascicle of the left bundle branch, resulting in right axis deviation of the heart's electrical axis on an electrocardiogram, ECG, without other identifiable causes of axis deviation. Number 3. Etymology. Left refers to the left side of the heart's conduction system. Posterior indicates the fascicle that transmits impulses to the posterior-inferior wall of the left ventricle. Hemi means half or partial, referring to one division of the left bundle branch. Block denotes interruption or delay in electrical conduction. Number 4. Epidemiology. LPHB is less common than left anterior hemiblock, LAHB, often seen in patients with ischemic heart disease, especially inferior myocardial infarction. Most frequently occurs in elderly individuals due to fibrosis of the conduction system. Often coexists with right bundle branch block, RBBB, as part of a bifascicular block. Prevalence is not precisely established due to its subtle ECG findings and frequent co-occurrence with other conduction abnormalities. Number 5. Types. Though LPHB is not commonly subclassified, it may be considered in the following contexts. Isolated LPHB. LPHB without associated conduction defects? Very rare. Associated bifascicular block. LPHB along with RBBB is common. Intermittent LPHB appears sporadically on ECG. Persistent LPHB, present consistently on ECG. Trifascicular block involves all three fascicles, RBB, LAF, LPF, often leading to complete heart block. Number 6. Causes. LPHB typically arises secondary to disease processes affecting the conduction system, such as coronary artery disease, especially inferior wall myocardial infarction, hypertension, degenerative fibrosis, e.g. Lev's disease, Lenneger's disease, idiopathic conduction disease, cardiomyopathy, e.g. dilated hypertrophic, aortic valve disease, e.g. aortic stenosis, cardiac trauma or surgery, electrolyte imbalances, e.g. hyperkalemia, drug toxicity, e.g. digitalis antiarrhythmics. Number 7. Risk factors. Advanced age, previous myocardial infarction, hypertension, diabetes mellitus, cardiac surgery, smoking, obesity, family history of cardiac conduction disorders, use of cardiotoxic drugs. F8. Complications. If left unrecognized or unmanaged, LPHB can lead to progression to complete heart block, sudden cardiac arrest, especially with associated conduction abnormalities, syncope or pre-syncope from transient bradyarrhythmias, heart failure if associated with extensive myocardial damage, increased risk of ventricular arrhythmias, pacemaker dependence in advanced conduction disease. Number 9. Pathophysiology, step by step. 1. Impulse generation, begins in the sinoatrial SA node. 2. Atrial conduction. The impulse spreads through the atria and arrives at the atrioventricular AV node. 3. His Purkinje system. The impulse travels down the bundle of His and splits into right and left bundle branches. 4. Left bundle branch division. The left branch further divides into left anterior fascicle, left posterior fascicle. 5. Conduction block. In LPHB, the left posterior fascicle is blocked, delaying impulse conduction to the posterior-inferior wall of the left ventricle. 6. Abnormal depolarization. The ventricles are depolarized via the left anterior fascicle, causing the impulse to spread from the anterolateral to the posterior-inferior region. 7. ECG manifestation. This abnormal conduction results in right axis deviation, QRS axis plus 90 degrees to plus 80 degrees, typically without QRS widening. 10. Signs and symptoms. Often asymptomatic but may present with dizziness, lightheadedness, syncope, fatigue, palpitations, exercise intolerance, symptoms of underlying heart disease, e.g. angina, Vevin, diagnosis, electrocardiogram ECG findings, right axis deviation, 90 degrees to 180 degrees, normal or slightly prolonged QRS duration, 100 milliseconds, no evidence of right ventricular hypertrophy, no right bundle branch block, small R waves with deep S waves in leads I and AVL, small Q waves with tall R waves in leads 3 and AVF. Other investigations: Holter monitor for intermittent conduction blocks, echocardiography to assess for structural heart disease, cardiac MRI in suspected cardiomyopathy, electrophysiological study in complex cases. Nursing diagnosis: decreased cardiac output related to conduction block, risk for injury, falls, related to syncope, activity intolerance related to reduced perfusion, anxiety related to potential progression to complete heart block, deficient knowledge regarding the condition and its implications. No. 13. Medical management, observation for asymptomatic cases with isolated LPHB, treat underlying causes, e.g., manage hypertension, treat myocardial infarction. Avoid AV nodal blocking agents, e.g., beta blockers, calcium channel blockers if bradyarrhythmias are present. Antiarrhythmic drugs if associated arrhythmias are present. Pacemaker implantation in case of progression to bifascicular-trifascicular block, symptomatic bradycardia, recurrent syncope due to conduction system disease. Number 14. Nursing management, monitor ECG for evolving conduction abnormalities, assess for symptoms of bradycardia or syncope. Provide fall precautions if the patient is dizzy or at risk of fainting. Educate on symptom recognition and when to seek help. Prepare the patient for pacemaker procedure if indicated. Offer emotional support and reduce anxiety through reassurance and education. Number 15. Treatment options, lifestyle modification, diet, exercise, smoking cessation, medication optimization, avoid drugs that worsen conduction, treat hypertension, CAD, pacemaker, dual chamber or ventricular pacemaker in symptomatic cases, revascularization in patients with ischemic heart disease, monitoring, regular ECGs and Holter monitoring in patients with conduction issues. Number 16. 5 psychosocial interventions. 1. Health education, help patient understand their condition and how to manage it. 2. Cognitive behavioral therapy, CBT, to address anxiety and depression related to chronic illness. 3. Support groups, peer interaction to share experiences and emotional support. 4. Family counseling, involving loved ones in patient care planning and support. 5. Stress management techniques, breathing exercises, mindfulness, yoga to enhance coping. 17. Prevention, control hypertension and diabetes. Manage ischemic heart disease early and aggressively. Avoid cardiotoxic medications unless absolutely necessary. Routine ECG screening in high-risk patients. Healthy lifestyle, balanced diet, regular exercise, stress reduction. 18. Conclusion. Left posterior hemiblock is a rare but clinically relevant conduction disturbance. Although it may be asymptomatic, it is frequently a marker of underlying cardiac pathology, especially ischemic heart disease. Accurate ECG interpretation is critical for diagnosis. Comprehensive management involves treating the underlying cause, monitoring for progression, and educating patients on symptom awareness. Nurses play a vital role in early detection, patient support, and ongoing care to prevent complications such as complete heart block or sudden cardiac death. Would you like this as a downloadable piece? Thank you. Have a nice day.